Good afternoon, John. Good afternoon, audience. I have no financial disclosures, unfortunately. And does anybody know what this is? This we have replaced. Over the last 30 years, this has pretty much died down and no one even knows what it is. When you look at this, you realize we used to read these and think we had absolute certainty about what was contained within them. This is a venogram, and frankly, it was probably not a gold standard. And really, this came along in the mid to late 80s, and it's venous ultrasound. An extraordinarily simple technique, which we probably have tried to make a little more complicated. But this came from the first article I wrote in '86, and all it showed was that if you dimpled the overlying skin, a normal vein would collapse, and an abnormal vein, which would be located, let me see, yeah, there you go, which is here, won't collapse. It was that simple. And you can see here normal veins winking at you down below, and an abnormal vein over here, in spite of compression, in the saphenous vein, the femoral, will not collapse. And it's that simple. A lot of other things we've added to it, but you know, the topics for the discussion this afternoon is talk about compression, and I have, and then look at some of the other items. Many of these items may be somewhat new to you. They came from the consensus panel last year that Larry Needleman headed up, and we're waiting for publication of the paper soon. And some of these are going to be a little different than maybe what you've done before. There was a lot of sentiment that one would only do venous ultrasound with a certain degree of suspicion. And that has become, from the Image Wisely, the internal medicine group, everything. We ordered too many imaging tests. There should be sufficient screening for this. So one of the items that the consensus panel has proposed, that you have either a D-dimer or a Wells evaluation that is positive. Now don't panic, this is not going to decrease your volume that significantly, because this is the Wells criteria. You need 2 points here. You can look at this and realize you probably can come up with 2 points on this without too much difficulty. I mean, I look at you know, bedridden for 3 days and localized tenderness or vein swollen or leg swollen. It doesn't take that much, but there has to be some screen. And I think, you know, in this day and age, there's just too many studies done without any real probability. And the test of choice is the complete duplex ultrasound test. Now, what is a complete duplex? Well, it's compression of the deep veins from the inguinal ligament using selected Doppler, and we evaluate the calf, particularly the posterior tibial and the peroneal veins. And you're going to say, gee, that's maybe more than I really think I need, but it's really what the consensus panel came up with. And we were driven by vascular medicine people, vascular surgeons, ER docs. Everybody was on board here. And this is, you know, this is your normal anatomy. You see the common femoral running down to the calf. And what kind of tests are performed by different people? Well, the 2-point compression exam is really 2 areas that are compressed, the femoral and the popliteal, and that only. And who uses that? The ER docs are find it very quick and slick and pretty good. The problem is there's a gap here. There is no definition of, and no definition down here. There's 2 gap areas that are not included. But for the ER docs, they kind of attest to this is pretty good, but it is not as good as what we really can do. And then we have the extended compression ultrasound, and this is what we started out with in the 80s. Remember, any of those old enough to remember, there was no Doppler on ultrasound machines in the mid-'80s, late 80s. I mean, that came along later. So you basically just looked at this area down to the knee and just below into the popliteal. Then we've asked for people to do complete compression ultrasound, which runs all the way down to the calf. But what the consensus panel is recommending, complete compression ultrasound and with some Doppler evaluation at the common femoral, and look at both sides and make sure they're symmetrical, and using some Doppler also in the popliteal. So that is what the consensus panel is asked people to do. And that's what the SRU position paper will be. Now, hitherto, you know, calf vein analysis was done 1 of 2 ways. You did direct imaging, what you should see down here, and you're looking at the tibial veins that are occluded, Or you could do serial imaging. And serial imaging, the concept was, well, I'm not going to look at the calves, and if the patient has continued symptoms, come back in 3 to 5 days. And you know, most clot actually originates in the sural veins down here, and then in the gastrocs and these other calves, everything starts down below. So if you're not looking down there, you're leaving something exposed. This is the very first case where I ever had. This is about 1985, 86, where I looked at and I realized the importance of being willing to do a follow-up study. I was kind of young and stubborn, and I did this study, and I was just, you know, espousing the technique, its value, and the popliteal here compressed beautifully. And the physician, one of the physicians called me back and about a week later and said, my patient's leg's getting worse. And I said, well, he doesn't have DVT. And then he kind of persisted, and I said, oh, send him back. And this is what he looked like 9 days later. And then I realized the popliteal was full of clot, that this does happen, and it happens routinely, that you can have propagation of clot from the calf vessels if you don't look at them. That's going to happen. So you either look at them or do serial imaging, and the committee and the consensus panel says, look at it. So what's the advantage of doing this complete duplex ultrasound? The best thing is we cut out the Tower of Babel. Everyone's on the same page. Everyone does the same study. So you don't have this issue. You can detect calf clots, present probably in 10% of the time, just isolated to the calf, never make it up to the popliteal or one of the higher vessels. You don't have to do a second look study routinely. And most of us don't do second look studies routinely, and we only do a second look if there's a real issue, if the patient persists in having problems. And there's, you know, the number's kind of hard to come up with, but probably something around 16% of calf clot's going to make it into the popliteal. And then also your symptomatic areas get evaluated. So in the complete duplex ultrasound exam, we solve a lot of problems and kind of bring a lot of things to rest. Calf clot still remains a challenge, though. I mean, we have great sensitivity for clot in the popliteal and above, probably 98, 99%. I mean, it is much better than the venogram, trust me. And then the calf, it drops off. We're not as good. And the problem is, what is the modality the technique that's most effective is compression. And it's hard to compress some of those calf veins. The anatomy is protected by the bones and the fascia. So we only do the calf in the past if the patient had persistent or worsening symptoms. And we had pretty good results. The outcome analysis showed, you know, patients weren't dying of PE in spite of this. And, you know, we got pretty good. I mean, here's a solio vein clot we could pick up, and we were doing okay. So the calf veins, you know, people always wonder what we're talking about. So in the initial venous ultrasound exams we did in the 80s that just go from the fem to the pop, they do go below the knee. And I have had many times involved with med-mal cases, a radiologist will say, well, I never go below the knee. That was not a part of the problem. The popliteal goes below the knee joint in almost every human being I've ever evaluated, you know, and it goes down a couple of centimeters. So you don't use the term "you don't go below the knee." That really gets the plaintiff's attorney. They love that one. And then you have posterior antibial and perineal veins, paired veins in the deep system. And then we have two other characters, the gastrocs and the soleus. Now these are muscular veins. And a lot of people just blow off the significance of these. But these are deep to the fascial plane. So they are technically deep veins. And Larry and I, at least I was, but we were at the consensus panel, the vascular medicine people said they want to know if there's clot in the muscular veins. That is very important and will influence them significantly. So, you know, maybe we don't think much of them, but it does have value. So I alluded to the medical mal case, and I have been involved with several of these, and the Tower of Babel problem here is exuberant. You have the AIUM saying you got to look at the calf veins. ICOVAL says, well, when it's appropriate. ACR, when it's necessary because of symptoms. And all of this can be used against you so readily. And I've been involved with cases where the radiologist didn't look at the calf veins. They ask him if he knows what AIUM is. They read the AIUM criteria. They bring some expert in and says you should have looked at the calf vein. Next thing you know, the guy lost the case. So this would be solving a lot of problems. The SRU basically says, look at the calf veins routinely and we won't have a problem. And treatment of these, you know, yes or no. I mean, the vascular medicine people on the panel extended this. Let us decide if you want to treat. You shouldn't be making that decision. We'll look at the whole ball of wax in the picture. And don't forget, treatment doesn't dissolve the clot, but what it does, it prevents further progression, and down the line, you won't have huge insufficiency and develop a lot of varicosities. That's probably the most important reason. Now, the complete duplex ultrasound isn't perfect because of the calf, and if you had persistent symptoms with the complete duplex ultrasound and the guy was getting worse, you should repeat that study too, because we can miss calf clot with this test. And I did allude to the fact that when you do the femoral evaluation with Doppler, you're looking at both sides for symmetry, and that's to assess uphill issues, compression of the vein or an occluded vein uphill. So what about the gastroconsolial veins, which are muscular veins? They certainly can propagate into the tibial and perineal. They can extend all the way to the popliteal in about 3% of patients. There's data that says if you had clot down there, it's going to either decide to go away or make its position established in about 2 weeks. And I think this slide is from Larry, actually. I was trying to figure out where it was from. But it shows a small clot in the solio on an 814, and then a clot you can see here making its way into the tibial vein on 818, and then in the popliteal, full of clot on 826. So that took 12 days to make this progression. But it happens, and if you were not to have seen this solio clot on the first study, and the patient now was getting worsening symptoms a week later, you should repeat the study. It's that simple. Now, what is the issue of the calf clot, why they're so difficult? Well, as I alluded to, compression isn't available, but the real issue is there's a lot of small calf clots that exist in studies that are really asymptomatic, and they're less important. And you don't want to get too carried away with those. So you have the symptomatic patient who has pain in the calf, swelling in the calf. And then you have asymptomatic, where you have focal clot on valves. And these are pretty routine. You sit here for the next until the break, and when you stand up at break, you're going to flick off these little clots from your valves. There's routine. I firmly believe everyone does this. And that should not be held as something that we can't look for. This is not something you need to detect, really. So there's articles that have looked at in the orthopedic literature for years talking about how asymptomatic DVT, when you're looking at patients sort of screening them routinely, you're going to miss a lot of the calf clots. And that's probably true. We know we can't compress, and a lot of these clots are very small. And therefore, it's not that important. So this is I'm going to just divert for a second to look at these calf clots, these small asymptomatic ones, and what are they? I mean, here are your valves, and the valve cusps close when you stand up. They come together, blood rushes down, they coapt, and they prevent flow from going downhill. Clot can sit on the valve cusp, and it sort of forms like this. And then when you stand up, this little thing kind of flicks up and goes to your lungs. And they usually never get this big. The problem is, if it gets this big, it starts to get significant. And that's the unusual aspect. Hopefully, it doesn't happen very often. So here you see a patient with color Doppler, or power Doppler, I guess, and you can see behind the valve here, there is a clot formed. And you can see this is a more dramatic picture of it. Here are the two valves, and you got stagnant flow occurring behind these valves. And that stagnant flow is where, as you sit here and you're not getting muscular contraction, where little tiny clots can form. So we're not talking about the clots that do this in the lungs and PE. We're talking about these little tiny dots that form down here in the lung, which I call normal clots of daily living. And there have been reports in the literature of routine CTs of the abdomen. The lung base is 4% of people, they pick up small dots, small PE. That's in multiple studies with high definition CT scanners, picking up 4% of people have small clots. They're the same clots that if we scanned everybody here in this room after sitting for 2 hours would probably have. So it's this little clot that sits here. This is not what we're worried about, frankly. It sits here and it causes this little dot. And these are pretty much normal little devils. So I diverted there just to discuss what we're not really worried about. We're worried about the occlusion that's occurring in the tibial, peroneal, soleal veins. Now, the last important topic, and one I think that's very, very important, is the evolution of DVT. And if you have clot in the veins, it stabilizes with treatment, stabilizes in the course of about a week to 10 days. So that clot sits there now, it's stabilized. Don't forget, heparin does not dissolve clot. So you put patients on heparin and they got clot load there, they're not forming any new clot. What happens to that clot? Well, it kind of stabilizes. Then it undergoes a process of healing, and that can occur over almost 6 months. Most of it probably occurs in the first 3 months, but up to 6 months. And do you heal completely? Well, about half the people heal completely, and about half don't. And what's the best predictor of how much healing you're going to get? Your age. The younger you are, the better you heal. And clot load. Large clot loads and probably not going to completely resolve. Now, when you have this effect, this is left behind some material in the vein. And I would guarantee you that if you were to look at the typical day in the United States, I would bet somewhere between 10 to 20% of the patients who are called acute DVT actually do not have acute DVT, instead have this chronic post-change. And so if you looked at 100 patients, 50% are going to go to normal, and 50% will be left with some chronic change. The chronic material is stiff. It reduces the size of lumen, but the lumen is still patent. There's no inflammation going on. The baseline can occur over 3 to 6 months. The problem is, in Europe, they've established the fact that if you see this residual scarring material, that the patient should stay on anticoagulation longer, because what's the #1 risk factor for acute DVT is prior DVT. And they're claiming that this scar material actually sort of sets you up for additional issues. So recurrent DVT is a difficult diagnosis and often masquerades as acute DVT. Now, what's the terminology? The terminology, the committee, the consensus panel decided you should call this residual material, which is sort of a scar, but give it the name chronic post-thrombotic change. So chronic post-thrombotic change. And what happens here, if this is a transverse image of your initial vein, you had clot. It can be asymmetrical, but frequently there's a rotor-rooter effect where it just kind of drills through and you have a new lumen. Well, a new lumen here is all you can expect to compress. You can't expect that the outer wall now is going to touch the outer wall because of this post-thrombotic change here. And this is all you're going to see that's going to change. So in summary, you have an acute clot, and it can go to normal, 50%, or it can be left with this post-thrombotic change. Now, my point I made several minutes ago was, unfortunately, this probably is routinely diagnosed as acute DVT in most scenarios and puts the patient back on anticoagulation when it's totally unnecessary. So the evolution is, this is an important point, and the committee thought it was a point that was not well understood. Acute clot evolves. What's left in 50% of people is called chronic post-thrombotic change. The residual lumen can exist with still some scarring there, and the residual lumen can contract. And if you have a patient come in and you don't know if, geez, they said they had an episode before and they had chronic, but I don't have the images, I don't know where it was or anything, you can do one thing, you can check a D-dimer. And if the D-dimer is negative, you should not have acute clot. The other thing you should do the study and then repeat it in 1 to 2 days, looking to see if there's any change or evolution. Acute process will change, a chronic process is going to sit there and not change. So, you got to have some alertness and concern that this is in the possibility. All right, thank you very much.